Hi everyone, welcome back to Izzy Medicine. This is going to be part 1 of our 3-part acute coronary syndrome series, and we're going to address it from the first chest pain all the way to recovery. Today we're going to start at the bedside with our patient, and we're going to figure out what's happening inside their arteries. Part 2 will cover ECGs and troponins, and part 3 will bring it all together with management and complications. So let's meet our patient. A 57-year-old man walks into your emergency department. He's clutching his chest. He's pale, sweaty, and uncomfortable. He says it feels like pressure. It started 30 minutes ago while walking to his car, and it hasn't let up. His heart rate is 98. He's borderline hypotensive at 98/54, and his SAT is at 94%. He's got hypertension and high cholesterol for history, and you've got a situation on your hands. But it's important to remember that not every ACS patient looks like this. Sometimes you might have a 68-year-old woman who's feeling wiped out and nauseous, or a diabetic man may complain of shortness of breath. Women, diabetics, older adults, they often present atypically. They can have fatigue, indigestion, dizziness, jaw pain, back pain. These could all be cardiac. Anytime the story feels off, our internal alarm should be asking, could this be ACS? So what is acute coronary syndrome? Well, it happens when one of the heart's own arteries suddenly can't carry enough blood and oxygen. Each coronary artery supplies a section of the heart. If that artery gets suddenly blocked, the part of the heart that it feeds doesn't get oxygen. Without oxygen, the muscle first becomes weak, and then if the blockage lasts, those cells start to die. That's the whole problem in acute coronary syndrome. It's a sudden loss of blood flow that threatens the heart muscle itself. So what happens? How do we have this sudden loss of blood flow to begin with? Well, it all starts with a ticking time bomb, a plaque. A plaque forms when cholesterol and fat builds up inside the artery wall. The body responds to it by covering it with scar tissue called a fibrous cap. Basically, it's trying to keep the fatty core sealed away from the blood. We can have a stable plaque, and here the fibrous cap is thick and firm. This happens when smooth muscle cells from the artery wall build up scar tissue over this fatty core, and they create this solid covering. These plaques usually just sit there. If they grow large, of course, they can narrow the artery and cause a predictable pattern of angina with exertion. Patient can have chest pain climbing stairs or walking, but it usually improves with rest. These kind of stable plaques are far less likely to suddenly rupture. But then we have our unstable, vulnerable plaque. In some cases, what happens, inflammation takes over. White blood cells move in within the artery walls and they release enzymes. These enzymes weaken and thin this cap instead of reinforcing it. Now what happens? We have a thin, fragile covering over the soft, fatty, and inflamed cholesterol core. And the dangerous part is, these plaques don't even have to be that big. On an angiogram, sometimes they might block only 30 to 40% of the artery. So the patient might not even have any warning signs. But because the cap is weak, they're primed to rupture. Why do some plaques end up with a thick, solid cap, while others are thin and weak? It all depends on this balance between repair and inflammation inside the artery wall. When risk factors are controlled, if we're able to lower LDL through medication or dietary changes, if the patient stopped smoking, if their blood pressure is under control, the smooth muscles lay down scar tissue and keep the cap strong. If we have a patient with risk factors that are uncontrolled, their LDL is still high, their hypertension is not controlled, their diabetes is not well managed, they're still smoking, their artery walls stay inflamed. That continues to bring white blood cells that release enzymes and chew up the cap, and that leaves it fragile and easy to tear. Unfortunately, once the cap is fragile, it doesn't take much to push it over the edge. Everyday stressors can act as the final straw. So what are common stressors? What can make this cap suddenly break? Well, exertion. For example, like our 57-year-old patient, just walking to his car raised his blood pressure and heart rate enough to strain that weak spot. Sudden BP spikes, a quick surge in pressure can split a thin cap. Morning hormones, cortisol, adrenaline, they peak early in the morning. They cause rising BP, they speed the heart rate, and they make platelets stickier. That's one reason why heart attacks are most common after waking in the early morning hours. Additionally, stress and illness, emotional arguments, infections, even the flu can add inflammation and pressure that destabilize the plaque. So in our patient's case, his risk factors are already thinned the cap. That morning walk was the last straw. The cap cracked and the core spilled into the blood and acute coronary syndrome began. What happens when this core spills into the blood? Well, once the cap tears, the fatty core spills into the bloodstream. To the body, this looks exactly like an injury, like as if we've cut our skin. That's when platelets rush in first. They stick to the torn surface. They change shape. They call in reinforcements by releasing chemical signals. Very quickly, they start building a sticky plug. Then, the clotting proteins join in. They trigger fibrin to form, protein strands that lock the platelets together into a firm clot. This particular process, it saves you when you cut your skin. But inside a coronary artery, it turns into a dangerous blockage. That healing clot doesn't repair the artery, it obstructs it. Blood flow slows or even stops, and now the heart muscle is starved of oxygen and actively dying. So what are our spectrums of acute coronary syndrome? Well, we can have unstable angina. Unstable angina happens when the artery is only partially blocked. Blood can still get through, but not enough to meet the heart's demands. The muscle is ischemic, it's starved of oxygen, but it's not yet dying. In unstable angina, troponins usually stay normal. Clinically, this shows up as chest pain that's new, worsening, or happening at rest. If the blockage gets worse, this is where we get into our non-ST elevation MI, our NSTEMI. Now, some of the heart muscle starts to die, usually in the inner layer of the wall, the subendocardium. That's the most vulnerable part when blood flow is low. This partial thickness injury does release troponins into the blood, so they rise when we check. On the EKG, we won't see ST elevations, but we may see ST depressions or T-wave inversions. This is still a heart attack, just not a full thickness kind. And then, when the artery is completely blocked, we get our ST elevation MI, our STEMI. This is where no blood gets past the clot. All of the muscle it supplies is at risk, and the injury goes through the full thickness of the wall, a transmural infarction. This produces elevated troponins, of course, but also the classic ST elevations on EKG. Every minute of delay means more irreversible damage. The key point is that the ACS spectrum is dynamic. Unstable angina can evolve into an NSTEMI, and an NSTEMI can progress to a STEMI, sometimes within hours. That's why serial EKGs and repeat troponins are so important. A patient can look stable on arrival and then show EKG changes and rising troponins later. A normal EKG at triage doesn't mean you can relax. It just means that the story isn't finished yet. Alright guys, that was part 1 of our ACS series. In part 2, we'll dive into the detective work. We'll review EKGs and troponins. We'll talk about how to spot ACS early, even when the first tests look normal, and how to localize the infarct. Thank you for watching Izzy Medicine. If this helped you understand why heart attacks happen, hit like, subscribe to the channel, and of course, queue up for part 2. I'll meet you there. Bye!